Hello, everybody, and welcome back to Health Confidential. Today, I have the distinct honor of welcoming one of the most prolific voices in the world of cancer, the one and only Dr. Thomas Seyfried. Dr. Seyfried is a renowned professor of biology at Boston College and the leading figure in the field of cancer metabolism. His groundbreaking research challenges the conventional genetic paradigm of cancer, proposing instead that cancer is fundamentally a mitochondrial metabolic disease. His seminal book, Cancer as a Metabolic Disease, on the origin, management, and prevention of cancer, has been instrumental in reshaping our understanding of cancer origins and treatment strategies. His work actually emphasizes the role of mitochondrial dysfunction in cancer development and advocates for metabolic therapies such as the ketogenic diet as a non-toxic treatment option. His research has opened many new avenues for cancer management, focusing on the metabolic vulnerabilities of cancer cells. Please join me in welcoming Dr. Thomas Seyfried to our podcast. Hello, everybody. Welcome back to Health Confidential. I've been wanting to speak to this most amazing, prolific figure in the world of cancer for such a long time. And that is Professor Thomas Seyfried, one of the boldest voices in the cancer research today. And his work has radically shifted how we understand and treat cancer. I've actually gone and I've taken a deep dive on his work when my dad got diagnosed with cancer. We're not just talking about medicine, we're talking about mitochondria. This is the work that he's been doing tirelessly for such a long time about metabolism and, most importantly, the food we eat, because we eat multiple times a day. So I'm sure you could see the relation between cancer and the food that we eat. So if you are someone that you've loved or love has been touched by cancer, this conversation is going to reframe everything. I promise you that. I really want you to hear what Dr. Seyfried has to say because it's one of the most important things you'll ever hear. I promise you that. Dr. Seyfried, welcome to my show.
Oh, well, thank you very much. It's a real pleasure to be here. Thank you.
Let's begin with your book. So in your book, Cancer as a Metabolic Disease, you wrote that dietary restriction, and especially the restricted ketogenic diet, are the only known therapies that can simultaneously target tumor cells. And this is very important for those listening, while it enhances the health and vitality of normal cells. And this is important because typically chemotherapy destroys everything in its path, including the healthy cells. Mm-hmm. And as a nutritionist, which is what I've studied, especially since I myself had to walk through the whole idea of the medical world from something that I've suffered myself, I want to start with food. You've positioned the keto diet not just as supportive, but rather therapeutic. In the research that you've done, are all cancers responsive to this? Would it apply to, let's say, hormone-driven cancers like breast cancer or cervical cancer, or does it depend on the location and the type?
Yeah, well, thank you. Well, I think we have to redefine what we're talking about when it comes to this. It's not so much the ketogenic diet; it's nutritional ketosis, which can be achieved by almost any diet. As long as you can lower your blood sugar and elevate your ketones into the ranges that we have proposed, which is a glucose ketone index of about 2.0 or below, regardless of whether you're eating a pescatarian diet, Mediterranean diet, ketogenic diet, carbohydrate diet, fat diet, doesn't make any difference. Every individual will come to know what they can or cannot eat, bringing them into the range of nutritional ketosis. As long as the diet is balanced nutritionally for macro and micronutrients, people will know what they can or cannot eat. So it's up to each individual. That's why we developed the glucose ketone index calculator, which takes the ambiguity out of what I can eat and what I can't eat, and can I do this? We don't know. Everybody's a different individual. If you want to manage cancer, it's important to keep blood sugar low and ketones elevated within what we call normal physiological ranges. Essentially, we're just bringing ourselves back to the kind of existence that our Paleolithic ancestors had 500,000 years ago. These guys were always in a state of nutritional ketosis, mainly because they didn't have access to poorly nutritious, these kinds of highly processed carbohydrates. They had much more exercise than we did. They lived on a light day-night schedule that was more regular in their lifestyle. They had a lot of exercise, and they ate predominantly meat, berries, and nuts, and anything they get their hands on. Anything walked, crawled, or flew, or swam is our ancestral existence. And
Hmm.
at that time in our history, cancer would have been extremely rare. All these chronic diseases would be extremely rare because we didn't have the provocative insults to our system in those days. So you have to realize what killed Paleolithic man was injuries and infections. They had no antibiotics and they didn't have orthopedic surgeons to fix their broken hips or bones or whatever. So that was what was killing them, not cancer, not type 2 diabetes, dementia. How do we know this? Because we have people living on the planet today that live according to their traditional ways, and we don't see Albert Schweitzer and a number of other physician people. They went around. They said, "Whoa, why is cancer so low in these guys?" Well, they're living according to their traditional ways. It's when you live according to your traditional ways, you have very low a risk for chronic disease. We're not living according to our traditional ways today. So consequently, we're assaulted by all kinds of inflammatory provocative agents that put us at risk for cancer, dementia, type 2 diabetes, high blood pressure, cardiovascular, we have an obesity epidemic. All this is perfectly explainable. So you just have to know evolutionary biology, where we came from and where we are today. Our technology has evolved so much faster than our biology. We're still Paleolithic man living in a modern age where we're assaulted by all of these things in our environment. And these produce all these chronic different kind of diseases. So when you do a glucose ketone index calculator, ketogenic diet, keto, whatever it is, you can then put yourself in these healthy zones. And as long as you can stay in these healthy zones, the probability of getting a chronic disease would be reduced, and the effect of managing a chronic disease would be enhanced, including cancer.
That's amazing. So then in that regard, what makes cancer cells unable to adapt to ketones while the healthy cells thrive on them, Dr. Seyfried?
Yeah, well, every major cancer that we have studied has abnormalities in the number and structure and function of the mitochondria. The mitochondria controls the destiny of our existence, and the existence of our normal cells and cancer cells. So cancer cells can't burn ketones or fatty acids because the very organelle needed for this metabolism is dysfunctional. And when it's dysfunctional, these fatty acids accumulate in the cytoplasm as lipid droplets, that we have published a major paper showing this. So they can't use fatty acids and ketones because the mitochondria are defective. On the other hand, the normal cells, which evolved to burn fatty acids and ketones, are quite capable of transitioning away from glucose to fatty acids and ketones. So that the cancer cells then become metabolically marginalized, and they can't adapt. We interrogated these cancer cells. They use glucose, the sugar glucose, and they use the amino acid glutamine, and they ferment these two fuels, and that's what drives the dysregulated growth. So the key to managing cancer is to simultaneously restrict the availability of the sugar glucose and the amino acid while the body is in nutritional ketosis. You know, that what I just said will become the standard of care for managing cancer once the field comes to understand what I've just said and the biology and biochemistry supporting what I just said, which we have already outlined and published over and over again. It just takes time for the field to read what we've written and come to understand it. And once that happens, then you're going to start to see major reductions in cancer and other chronic diseases.
I believe this wholeheartedly because I've seen the shift in so many of the people that I've worked with and even when I was doing my internship, I saw that the dietary approach was what shifted them so precisely and with such success. So how can patients, I mean, from the work that you do, how can patients advocate for metabolic strategies especially when their oncologists are not even aware of it or not supportive of it?
That's the million-dollar question. It is it is quite uncomfortable and unfortunate that you would think that the patients hear what I say, they read what I write, other people talk about it, and they get all excited and
Hmm.
hopeful. And then they go to the Dana Farber, the MD Anderson, the Sloan Kettering, the Fred Hutch, the Moffitt, all these top Mayo
Yep.
clinics. And they say, we never heard of this. And if it were important, we'd have learned it in medical school. The power of nutrition, the power of using metabolic therapy to manage chronic diseases. The tragedy is we're not training our physicians to know anything about this. So we have to configure the curriculum at the top medical schools in order for physicians to be trained. You know, they're working very, very hard. Most of them have interest in the outcome of their patients, but they have been trained by a system that is based more on pharmacy than on exercise and nutrition. So how would they possibly be able to prescribe that when they really have never been trained to know that and have never been exposed to the information supporting that? And another problem is many of them are locked into what we call standards of care that are written by the pharmaceutical industry and the medical establishment to provide a pharmacy and drugs and all these other kinds of things. And if you don't do that, you may lose your license. So radiation, chemo, pharmacy, all that stuff is part of the standard of care. And it's like written in granite, and it should never have been written in granite. So there should be flexibility. When something new comes along that's even more powerful and effective than what you're doing, you think there'd be some recognition that we might want to look into this more and see what the science behind it is. And we've clearly shown the science behind it. So that's the firewall. What is going on here? How is it possible that this enormous mega industry of the academic, pharmaceutical, hospital industry is not embracing this? I mean, our recent study on glioblastoma, where we used ketogenic metabolic therapy with our patients in Greece, where those who followed the metabolic therapy lived 66% longer than those that didn't. If we had a drug that did that, I'd be sitting on $1 billion right now. When you look at it, you go, "Oh my God, this is the most amazing breakthrough in glioblastoma history." And then you find, what did they do? What did they do? Yeah, well, they ate a calorie-restricted Mediterranean diet and got themselves into nutritional ketosis. Oh, I'm sorry, we can't use that. That doesn't fit that doesn't fit the program. So you're up against that. You're up against a lot of firewalls. But the issue is that this stuff works, and when it's done right, it's super powerful. And patients and the oncologists and physicians should all work together as a team because the outcomes will be remarkable.
Yes, especially if we want to keep the patients and positive outcomes for their health at the forefront and at the focus point of our work, which is, I know exactly what you do and what I do. So, Dr. Seyfried, so you talked about glioblastoma. If we were to look at cancers that are more hormonal in nature, which is what I've mentioned earlier, breast cancer. So these are the two most prevalent ones that I work with the people that I work with. Cervical cancer, ovarian cancer, breast cancer. Do these cancers behave exactly the same way? And are they just as responsive to this approach?
Yes, they are, because we looked at the biochemistry and biology of breast cancer, ovarian cancer. In fact, we looked at all the major cancers, melanomas, blood cancers, the whole range of blood cancers, all the digestive cancers, stomach, colorectal cancers, breast cancers, lung cancers. You go right down the list. We have not yet found any cancer that has a normal number, structure, and function of the organelle mitochondria, which is really responsible for the maintenance of normal energetic health. And that includes breast cancer. So we published several big papers on breast cancer and show remarkable therapy. The problem is right now is that everybody thinks all these cancers are different from each other based on the now replaced somatic mutation theory. the idea with that cancer is a genetic disease has now been debunked. It's not anybody who is not a dogmatic ideologue or a person linked to confirmation bias should know that cancer cannot be considered a genetic disease. It's a mitochondrial metabolic disease. So you would have to find a cancer with a normal number, structure, and function of mitochondria to not respond. And we have never found that. In fact, I've offered money to people. We said, please show us a cancer, any cancer that can survive without glucose and glutamine and burn ketones or fatty acids or anything other than the glucose and glutamine. So far, nobody's been able to do that. So we know breast cancer, colon cancer, they're all very much the same. They can't live without glucose and glutamine. It can't switch to fatty acids and ketones. Not that complicated.
Please tell us one of the best things that I've heard from you. I mean, I have so many quotes that I wrote down for this episode, but I wanted you to touch on this because this was one of the most important things I've heard anybody say in the world of cancer. So you talked about how if this was to be a genetic one, then that means that if you were to take people from the same family and you were to put one in another country and then one in this country, and can you go back to that and explain it in a way that the audience can understand so that they can actually understand that it's not at all a genetic thing?
Well, when we say it's not at all a genetic thing, we have genetic risk factors.
Hmm.
And we call them like the BRCA1 breast cancer mutations, and we have the Li-Fraumeni, and we have the retinoblastoma, we have the Lynch syndrome. We have all of these kinds of syndromes which make people think that it is purely genetic. What those things are basically genetic risk factors. What that means is they're secondary, they're not the primary cause. The primary cause of all major cancers is damage to oxidative phosphorylation in the mitochondria. All of those genetic risk factors do that. But like in breast cancer, the women that have the mutation, 50 or 60% of the women that have the mutation will go on to develop a cancer driven by fermentation metabolism, meaning that the gene disrupted the mitochondria. But then you get 40% of the women that have the exact same mutation never develop the breast cancer. So and you see that with many of the other so-called inherited risk factors, meaning that these will put you at risk, just like a chemical carcinogen, just like a virus or radiation or something like this. But you don't get cancer unless you damage that mitochondria. So if you keep your mitochondria healthy, you significantly reduce the risk, even if you have a genetic risk factor. As far as the separating, a lot of people think, oh, it has to be genetic because we have several members of the family that have this. Well, they're living in the same environment as well. They're probably eating very similar foods, no exercise, a lot of stress, all the same kind of thing. But when one of the studies that I remember seeing was a study out of Indianapolis, Indiana, where they took African Americans who lived in the Indianapolis area and looked at their genetic background and went back to Africa, where they would have similar genetic backgrounds for the individuals that were in Indianapolis. And there was a striking difference in what was causing unhealth. In Indianapolis, it was obesity, type 2 diabetes, and cancer, and high blood pressure, and this. And in Africa, it was like parasites and infections, and it was a very different series of ailments. The same, very similar genetic backgrounds, very different phenotypic outcomes as far as disease is concerned. So when you ferret out, like what's all this behind it? Yes, there are certain genetic risk factors that can be. I call them risk factors. They're not. See, certain genes, when we have like Huntington's disease, Tay-Sachs disease, cystic fibrosis, these are genetic mutations where they are the cause of the abnormal phenotype. In cancer, we have genetic risk factors that put you at risk, but can be modified significantly by changing diet and lifestyles. So even if you have the mutation, you could significantly reduce the probability of developing the phenotype, which is the disease, if you know that you can change your diet and lifestyle to keep your mitochondria healthy and then make the probability of getting cancer much less. Or you can do what Angelina Jolie did and have your breasts and ovaries and all this thing. That's called surgical mutilation. But that's an option. Some people want surgical mutilation. Some people might want to change their diet and lifestyle. So they should be allowed to know what to do and what they might want to do.
It's unfortunate, though, that they are only offered one path rather than choice.
Yeah, well, they need to be educated. One of the things that we do is scientific literacy. We have a massive lack of scientific literacy in this country. And when it comes to your health and your soul, which could be massively impactful on how you live your life, I think you might want to take a dive, especially and learn things for yourself, especially when the current systems and institutions regarding cancer are lack most of the knowledge that you need to manage the disease, because you would never be doing what we're doing to people today, which is surgical mutilation, nuking people with high dose radiation, using toxic poisons. I mean, I call these kinds of therapies medieval. I mean, these are medieval therapies done by people who were never trained appropriately to understand the biology and biochemistry of the disease they're treating. So the outcomes are not necessarily optimal. You have to realize today in the United States, in fact, the American Cancer Society has just come out and said we expect this year, 2025, to have 618,000 people die from cancer, which comes to 1,700 people a day dying from cancer, or 70 people per hour in the United States are dying from cancer. Why is this? Why do we have this huge tragedy? It should not have to happen. If you realize that this is a mitochondrial metabolic disease that can be managed effectively, you can significantly reduce the death rate for cancer. And we're not doing that because the powers to be think it's something other than what it actually is. That's what the tragedy is. That's the tragedy right there.
I understand. I remember when my father was diagnosed with cancer, and of course, they pushed him down the path of the three usual therapies: chemotherapy, radiation, surgery. And I remember when he finished his radiation, he was telling me that he didn't even want to eat meat anymore because he could taste burnt flesh in his mouth from the amount of radiation that they did to his chest. So I know exactly what you mean, which is exactly why I started studying what you're obviously have been doing such a phenomenal work at studying in depth to be able to provide not just the academia, but also just regular people so that they can adopt the things that work. So on that note, Dr. Seyfried, in the same book, which came out in 2012, by the way, for the audience, Cancer as a Metabolic Disease, you wrote this: I have presented substantial evidence showing that respiratory damage underlies the origin of cancer. Cancer is a disease of energy metabolism. And just for the listeners, because I want to clarify, when you say respiration or respiratory damage, that's referring to mitochondrial cellular respiration, not to the way that we breathe with our lungs. So I wanted to clarify that. But my question is, what happens to the mitochondria in cancer cells?
Yeah, so they're actually very well connected. You and I are both breathing. Every breath that we take in brings oxygen into our body. And oxygen is needed for combustion of our foods that we eat. Just like oxygen is needed in our automobiles. You have a spark and you have oxygen, and you create a controlled explosion that drives the pistons. If you have a gasoline engine, it drives the pistons of the engine, and you have an exhaust system that blows out waste products. When we inhale oxygen, that's the acceptor of the electrons to allow the oxygenation and combustion of fuel. And the fuel is what we eat. And every time we exhale, we are exhaling CO2, carbon dioxide, and water. And now those are the waste products of highly efficient energy production in our body taking place in the mitochondria of our cells. So the mitochondria of our cells are the little engines inside our cells, using oxygen to produce energy very, very efficiently with the waste products of CO2 and water. And the CO2 are the carbons from the foods that we ate. So we eat food, whether it's a meat, whether it's a vegetable, whether it's carbohydrate or anything, they have carbon molecules. Um, and the nitrogens of the meat, and they collect the nitrogen, and you can produce urea, which is another byproduct of metabolism. But by and large, we have a very efficient system. And in cancer, that organelle in the tumor cells is unable to use oxygen effectively, and they switch to another kind of a fuel called fermentation, which is an ancient way of getting energy without oxygen. And the waste products of that metabolism is lactic acid and succinic acid. These are molecules that contain carbon-hydrogen bonds that have not been fully combusted in our body, because the organelle needed for the combustion is defective. The cristae, if you look at the ultrastructure of this organelle, you find it to be very dysmorphic. It doesn't look healthy. It's got raggedy edges. It sometimes has it's we call them ghost mitochondria. The inner part of the organelle is like destroyed. So it's not able to fully combust the foods that we eat. And in order for that cell to survive, it has to transition away from oxygen to these ancient pathways of energy metabolism that go back to the very origins of life on Earth. 2.5 billion years ago, the organisms that existed on our planet there was no oxygen in the atmosphere, but they were dividing like crazy. They were like cancer cells. They were no regulation, and they would divide and divide and divide and divide until those fermentable fuels were used up, and then in the environment, and then they would die. In our body, the cancer cells are falling back on these same ancient pathways that have existed for billions of years, and they will grow out of control as long as they have the fuel glucose and glutamine in the environment. So once you take those two fuels away, it's like what would happen in the ancient times, that they would die up and die. So cancer cells are using fuels that don't require as much oxygen to generate energy. And energy is everything. Without energy, nothing works, and we die. And the best way to show that, or people say, well, what does that mean? Okay, if people were to drink cyanide, the Kool-Aid, they would say, drink the Kool-Aid, the cyanide in there. You die very, very quick. And that cyanide binds to the protein in the electron transport chain that uses that oxygen is dependent on. Oxygen is dependent on that part of the chain, and cyanide blocks that, and you die real quick. That shows you if you don't have energy, you're dead quick. Interestingly enough, cyanide does not kill cancer cells. It only kills normal cells, because the cancer cells are using this ancient fermentation pathway independent of oxygen. So and they said, what are they using for fuel? And it's glucose and glutamine. So if we take glucose and glutamine away, do cancer cells die? Yes, they die, because they can't get any other energy anyway. People have forgot about all this stuff. Once you understand, it becomes far less complicated than what everybody has made it out to be. So we all know that energy is everything. Energy is the key. Cancer cells get their energy in a different way than normal cells. They ferment. Normal cells respire. They use oxygen. Cancer cells can survive without oxygen. So we now know how to kill them without toxicity. The problem is what I just told you is either they don't want to know about it, they can't understand it, or they choose to do something different. So then it becomes, what does the people in the country want to do?
Yeah, and especially because we have so many prolific individuals such as yourself in the industry that are trying to bring forth what does work, and it's actually pushed back on. But Dr. Seyfried, so you said that back in the day, obviously in the absence of oxygen, all of these, let's say, organisms would obviously continue to divide. All of these cellular structures would continue to divide until they would run out of what they were using at that time in the absence of oxygen, and then they would die out. Would that happen to the cancer if we ran out of whatever the cancer is using in our body?
Oh, absolutely. And we showed that. That's why when we do calorie restriction and ketogenic restricted diets, we see a large number of dead cancer cells. And we know that because we use different markers. We use, apoptotic mechanism, necrotic mechanisms. There's a lot of ways cancer cells die. Mitotic catastrophe, we see that. And there's a whole field of biology that likes to study the various mechanisms of cell death. And they're quite sophisticated studies. Ferroptosis, as I said, mitotic catastrophe. You can go right down the list. We don't really care how we kill the cancer cell as long as we kill it, because when you kill the cancer cell, it ain't coming back. So, and I think people want to know, did you get rid of my cancer? The answer is sometimes we can, and sometimes we can't. We have some people that have lived with glioblastoma for 10 years. It never went away, but it was under control. And this is why for metabolic therapy, we don't ever say metabolic therapy can cure cancer. We say that metabolic therapy can manage cancer. Uh, how long, if a person's cancer is managed for 60 years and they die from old age of a heart attack, then you can probably say that metabolic therapy probably cured that guy. But if the guy dies from a heart attack and he still has the tumor that he had when he was 25 years old, if he's 80 years old, he was never cured, but he never died from the cancer. I mean, you can look at it
So
that way.
true.
So I don't like to use the term cure because it's an arrogant term, thinking that you really understand everything, and we don't understand everything. But what we do know is we can effectively manage many cancers without toxicity, allowing individuals to live longer with a higher quality of life and an improved overall survival. And I call that success. Whether or not you're cured, I consider that success. And we never and we also know that when we do metabolic therapy, we do not completely exclude standards of care. We think radiation, chemo, and some of these things can be utilized, but in a very different way, used much more sparingly at lower doses. Dosage timing and scheduling can be rearranged. Surgical approaches are always important for curing cancer. Surgery can cure cancer for sure, but you have to know how to do it when the tumor is now shrunken down to a one third, one quarter the size of what it was. The inflammation is gone. This thing looks like an indolent thing. Then you can take a surgical procedure and potentially cure it after it's been beat down by metabolic therapy. So clearly, physicians need to know that we have a new tool in the toolbox, perhaps the strongest tool that has ever been developed. But we don't throw out the other tools either. We just reconfigure how they're going to be utilized. Then you're going to get the real big effects. Then you're going to really see this disease effectively managed in the majority of people.
That's so important what you said. And I really want the audience to understand that those of us that are in the field and we want to help patients or clients, whatever you refer to them as, we actually are very open to integrating into the existing traditional therapies, whereas it's the other side in the medical world that is not embracing what we put out, such as metabolic approaches to it or food, whatever you want to call them. And it's unfortunate because it is a tool and it's one that's actually very underutilized and with it's very successful. This is all I use with the people that I work with. But I want to clarify something, especially for those in the fitness world, because we all know glutamine, and you did mention, is an amino acid. It's a non-essential amino acid, meaning that the body actually produces it naturally. And it's also found in a lot of foods. It's actually the most abundant amino acid in the bloodstream. And it actually plays a very important role and supports the immune system. So, how do we determine how to play with this particular nutrient in a way that it's going to give us the results we're looking for? Because if it actually supports the immune system and the immune system fights cancer, isn't this then an important aspect of what we do towards the cancer?
Yeah, absolutely. And that's why we wrote the Press Pulse therapeutic strategy for managing cancer, which is you can press glucose down real far uh, uh, um, with the dietary ketogenic metabolic lowering glucose and elevating ketones, and then using exercise as an additional method for lowering blood sugar because muscles will take the sugar out of the blood.
That's
The
right.
brain will take first dibs on almost all the sugar. Even if the liver is making a little bit through gluconeogenesis, most of it's going to go to the muscles in the brain, not the cancer cell. But that raises the issue about the glutamine, and that's why we can press glucose, but we must pulse glutamine
Glutamine.
targeting for the very reasons that you mentioned. We have found that the metastatic cancer cell, the cell that spreads around the body and is ultimately the most challenging part of cancer management, is part of our immune system. Uh, Metastatic cancer arises when a cell of our immune system, like a macrophage, which is a very powerful immune cell in our body, fuses with a cancer cell, like a cancer stem cell that cannot spread. But the macrophage is already programmed to move around the body. When that macrophage fuses with a cancer stem cell, you get a rogue cell, which has got a cancer cell that now has the apparatus to move in the bloodstream around the body and spread to different tissues. So when we discovered that it was the macrophage that was the origin of metastatic cancer, the first thing we did was we said, what do macrophages eat? And they're heavily glutamine dependent. So now we know that the very tumor cell and the immune cell, because if you kill a lot of cancer cells, you need normal macrophages to come into the microenvironment and pick up the dead bodies, the cancer bodies. If you don't, you get infection and you get all kinds of inflammation and wound and all this kind of problem. So you now are confronted with an interesting situation. The cell that will kill you needs the fuel, the same fuel that the cell that will help you. So, so what we do is we pulse glutamine targeting. So we use drugs that are just you put the patient into nutritional ketosis, and then you hit them with a small dose of glutamine targeting drug for a short period of time, which slaughters tumor cells, paralyzes our immune cells, but does not kill our immune cells. So we pull the drug off, our normal immune cells regain their activity and pick up the dead cancer cells. Now, of course, by adding a little glutamine back to the system, yeah, some of you don't kill them all at once. So you slowly degrade the cancer by pulsing glutamine and holding the chokehold on the glucose. And this is just the beautiful thing. So, but you got to know the biology. What are you doing, and why are you doing all this? Because I understand the biology of the cells that I'm dealing with. I understand the biochemistry and biology of the problem. So why should we poison the body with these toxic drugs that kill both cancer cells and the immune cells? So you really want to keep your immune system super healthy and degrade the ability of the tumor cells to survive. Our bodies are a healing machine. You give them the opportunity to heal, and they'll go after those tumor cells like a seagull on a beach sandwich. So they're a weak group of cells, these tumor cells, but the way we treat cancer, we keep those things alive. We give when you give all these toxic poisons to people, the blood sugar goes through the roof. So you're rescuing cancer cells by the treatments. Radiation makes your sugar go up. You give people steroids. All of that makes the blood sugars go up. And you're allowing those damn cells to survive on the sugar from the treatments you're giving them. But of course they're killing a lot of cancer cells, but they're killing your gut and they're killing your hair. What the hell will your hair go? I always say, why are you bald? When you see a bald-headed cancer patient, you say, "Oh, this poor guy. What did you have cancer cells in the in the follicles of your hair?" No, it's just kind of. You want to kill cancer cells, and you don't want to go bald, and you want to keep your gut healthy, and you want to keep all your organ systems healthy, while you degrade the tumor by pulsing glutamine and choke holding the glucose, and then transitioning everything over to ketones. The brain will transition, the heart, all these cells, and they become even more resistant to small doses of chemo. They're actually stronger now, even in the presence of small doses of chemo. But the tumor cells are extremely vulnerable under these conditions. So again,
I'd like to take a quick break now to let you know that today's show is sponsored by my book, Against Medical Advice. This book is a memoir, and it tells the story of how I built my life back after suffering a stroke during my divorce. I discuss the nutritional, lifestyle, and mindset aspects that I put into practice to regain my health and rebuild my life. The book has been a labor of love, both writing it and publishing it, and I couldn't be more proud of it. Please pick up your copy from Amazon. For your very own signed copy, my email address is simone@simonegissondi.com. Oh, and I'd really appreciate it if you'd please consider leaving a review once you've read the book. And now, back to the show.
So again, what I've outlined to you is the future of standard of care for cancer. And we're developing the strategies here. As long as we can continue to get revenue from philanthropy and private foundations, we are streamlining this whole process and making it better and better and better. And we're coming out with treatment protocols. We just have to get the medical community to understand what we're saying, and then you're going to see an enormous transformation in healthcare in this country.
That is the future for sure. And I want for the audience to know that it was actually in your peer-reviewed article called Press Pulse, a novel therapeutic strategy for metabolic management of cancer. And that's where you said the Press Pulse therapy strategy can be used as a framework for the non-toxic management of most cancers.
Yeah.
So on that note, Dr. Seyfried, what are some of the non-toxic pulse therapies that you believe hold promise? Because I know you spoke about the fact that you use a drug that can actually achieve that. But how about things like hyperbaric oxygen, glutamine inhibition? Are there any non-toxic ways of doing it?
Yeah, well, what we're finding now is that there are some parasite medications like M-bendazole and fenbendazole. I don't know about ivermectin, because I haven't studied that yet. And I was planning to study that, but it was a political hot button. I mean, everybody was screaming and yelling about ivermectin. No matter what you found, somebody would have a problem with it. So I said, to hell with that. Then we looked into M-bendazole, which is another kind of parasite medication. And we have a paper that we published for pediatric oncology in our pediatric model, which is, these poor little kids are brutalized who have brain tumors, and we're saying, well, look what they do to these poor little kids. So we have a preclinical model, and we used M-bendazole, and we found it actually restricts the uptake of glucose and glutamine. So, and it's pretty non-toxic. And when you put people into ketosis with diet and nutrition and this kind of thing, and then you come in with these parasite medications, you have a chance to actually manage the tumor without toxicity, which is really exciting. But they're not doing it because they think cancer is a genetic disease, and when you have the wrong idea of what you're doing, you're never going to get the optimal outcome. But the drug that we see is the most powerful, which is 6-deoxynorlucine, DON, DON. It was taken off. It was considered a little too toxic because it did have some effect on the gut, and it did, but its toxicity is no different than that of doxorubicin, which we call red devil, which causes your pee to be red, your eyeballs red. I mean, this is like a horrible poison. DON is not as toxic as that, nor is it as toxic as cisplatin, vincristine, all these horrible drugs that they give to people. Yet we're not using one of the most powerful drugs that we know of. Why the Food and Drug Administration doesn't allow DON? Because it's off patent. Nobody can make any money on it. So we have to realize in the cancer industry and in the entire industry, it's revenue generation first, patient outcome second. And that has been driving this industry for a long time. And it would be great if we could find a drug as powerful as DON that would be patented by some, and there are some at Johns Hopkins, they're working on some of these drugs. But the drug is already available. It's there, but we can't use it. Nobody wants to use it because you can't make money on it. So people got to know that. Don't forget, say it, revenue first, Patient outcome second. As hard as it sounds, but that's reality. That's the reality of cancer. So, and we got 1,700 people a day dying as the result of that reality.
That is probably one of the saddest thing, especially when they try to convince us that they want to help people. So, Dr. Seyfried, for everybody out there, because I get a lot of people that come at me with all cancers are caused by parasites. Can you touch on, especially because you studied it at cellular level, can you touch on what are some of the sources that really disrupt the mitochondria that leads to cancer, irrespective of where in the body, in what organ, in what tissue? Are there different sources?
Yeah. So cancer is not a parasite. Okay. Cancer is not a parasite. A parasite's a very different organism, a totally different organism.
Hmm.
What we found with parasite medications is that the parasite and the cancer cell use a common pathway to get energy. So the cancer and the parasite, cancer is not a parasite. It's one of a mammalian cell. It's not a different organism. But the parasite and the cancer cell use the glutaminolysis pathway, using glutamine as one of the fuels. So that's why parasite medications can work and kill some cancer cells. Now, what causes cancer? If you have an infection, if you have a parasitic infection in your body where parasites are there, they can, in certain areas, create inflammation around the parasite itself. A chronic inflammation in a localized zone will damage oxidative phosphorylation in cells around that parasitic organism, leading to the transition from oxidative phosphorylation to substrate level phosphorylation. This was what Otto Warburg had originally said. All we have done is we have followed Otto Warburg's suggestion that all cancers, his hypothesis that all cancers derive from chronic interruption of oxidative phosphorylation, coupled to a upregulation of fermentation, energy without oxygen. So that can come from chronic inflammation. People who have high C-reactive protein floating in their bloodstream is a marker for systemic inflammation, which could put patients at risk for developing a particular cancer in a particular tissue. You have viral infections. You have hepatitis C, papillomaviruses. What I have found is that these viruses can come into the cell. They can take up residence inside the mitochondria, disrupting oxidative phosphorylation, or they can go to the nucleus, produce a product that goes back to the mitochondria and disrupts oxidative phosphorylation. We have chemical carcinogens that people say, oh, this is a carcinogen. What does that mean? Oh, it's a chemical that causes cancer. How does it cause cancer? It goes into the mitochondria of the cell and causes the cell to autofluorescence. So you know that autofluorescence is coming from reactive oxygen species, damaging the mitochondria and putting those cells at risk for transition to fermentation. So we went through all of these different things. The older you get, the more likely your mitochondria will be damaged, the more likely older people will get cancer. So we have oncogenic viruses, we have intermittent hypoxia. It's like sleep apnea. We have obesity when you see very high levels of C-reactive protein in systemic inflammation. We have systemic inflammation, radiation. Radiation damages mitochondria, causing disruption of oxidative phosphorylation. We call this, was referred to as the oncogenic paradox, and the oncogenic paradox was initially outlined by the Nobel Prize winner Albert Szent-Györgyi, and he was scratching his head. And he said, how is it possible that so many things in the environment seem to be able to cause cancer? Parasites, all these kinds of things. And he says, what do you think the common pathophysiological mechanism might be that would link any of these provocative agents to dysregulated cell growth, which is cancer? And we resolved the oncogenic paradox. We showed that every one of these provocative agents, in one way or another, disrupts oxidative phosphorylation, allowing the cell to transition to substrate level phosphorylation, which is a fermentation. And that is the common pathophysiological mechanism. And not only that, When the mitochondria get damaged, they throw out these called reactive oxygen species, ROS. The hydroxide ion and the superoxide, they cause the genetic damage in the nucleus. So what's happening is as these mitochondria become chronically disrupted, they produce these carcinogenic compounds, these little radicals, which go and make the mutations in the nucleus. So when the field is studying all these mutations, they're actually studying downstream effects from the mitochondria. They're all downstream effects. They're not the cause, they're the effects. So we're spending billions and billions of dollars chasing effects rather than causes. Now we know what the cause is. Let's go for the cause. Why are we chasing effects? So once we understand the biology and biochemistry, this whole cancer problem becomes far less complicated than it was made out to be.
So true. So just so that I can recapitulate this so people can understand it, from the way that I understood it, all cells are normal cells until they have an agent, a provocative agent, as you call it, come into the cell and disrupt its mitochondria and the mitochondrial function, or they go inside the nucleus, as you said. And these once healthy, normally functioning cells are now becoming cancerous cells. Because I think a lot of people believe that cancerous cells are cells that come from outside somewhere, take residence up in the body, and all of a sudden we have cancer, as if it just came from nowhere. But it's actually our own cells that turn cancerous because of this provocative agent. Is that right?
Yeah, they come from within. I don't want to go down. It's not like a virus infection or contagion. It's not a contagious disease in that sense, like it's coming from outside our body. I'm not going to say that it can't be because there are certain kinds of cancers that are transmitted. The Tasmanian devil cancer. These are kind of a carnivore animal that lives in Tasmania, in southern Australia and Tasmania. They transmit cancer in their saliva. When they bite, when one animal bites another animal, they can transmit metastatic cancer in their saliva. There's also a venereal kind of transmission of cancer in dogs, where dogs can pass cancer cells from one dog to the next by genital licking and all this kind of stuff. These are well known examples of transmissible cancers. There are examples where some of the surgeons removing tumors from some people uh, cut themselves and allowing some cancerous cells from the tumor of the patient to get in, and they end up with a tumor on their hand or something like this. But these are extremely rare conditions. Most of the cancers that we know of are coming from our own cells being chronically damaged by one of the provocative agents that I've mentioned. So a woman could have a breast tumor as a result of an occluded milk duct that leads to a surrounding inflammatory condition that persists, leading to damage to oxidative phosphorylation in the mitochondria of a particular cell around the occluded milk duct. Or a woman could have inherited a BRCA1 mutation that would have done the same thing, damaged the mitochondria, or been exposed to a chemical carcinogen that's just so happened to accumulate in a particular cell of her breast. Any one of these things. But when you look under the microscope, oh, this is breast cancer, cell division out of control. But the origins from one woman to the next may be very different depending on her diet and lifestyle issues. But the end result is you have cell division out of control, driven by a fermentation metabolism. And if it becomes triple negative breast cancer, you know it's part of our immune system driven by glutamine. So you know how to kill it, you know how to manage it. And we know that from a lot of studies, lumpectomy versus mastectomy, there's no statistical significance in long-term survival whether the breasts are removed or the lump is removed. So what we think is that when you put these people when they're first diagnosed under metabolic therapy, you can shrink those tumors down, purge the metastatic cancer, and then do a quick surgical procedure to get rid of what lump might have been there. So the strategy for managing cancer becomes very, very different, and the outcomes become significantly better. But we're not doing any of that. We're tearing breasts off women. We're poisoning them. I mean, it's just like, what the hell are you doing out there? And the immunotherapies that are, you hear them advertised all the time on television,
Yes.
Opdivo, Keytruda, combinations of this. Okay, that's based on the somatic mutation theory. Those drugs are designed to attack uh, uh, markers on the surface of these tumor cells created by abnormal mutations in the tumor cell. Then they garnish the outside of the cell with these what we call markers, epitopes, and then our immune system is supposed to go in, see that marker on the tumor cell, and kill it. And about 20% of people that you get very excellent outcome. You really get sometimes removal of all the tumor cells. But in about 60% of the people, you don't get any better outcome than if you didn't do that and just use chemo. But then in about 15 to 18% of the people, those immunotherapies attack your liver and kidney and kill you faster than the tumor. So it's called hyper-progressive disease. And every oncologist knows this. And when you see the advertisements on television, they don't hide that. They spend more time telling you how that drug will kill you than how it will help you. So they're not hiding anything here. They're upfront. The problem is when you hear the commercial on television about, oh, this drug and that drug, then they spend all the time telling you how the drug is going to kill you. And people still go and use this damn drug, and I'm saying, what the hell? Don't the drug company told you specifically this drug can absolutely kill you? Why would you take anything with a remote chance of killing you? It's like playing Russian roulette. Okay, I have a 20% chance of getting a real good outcome, 60% chance of not doing anything, and maybe a 20% chance of having the gun go off, blow my brain out. This is this is with metabolic therapy we can significantly. The other thing is very interesting. These metabolic therapy, these immunotherapies, they say, oh, it's hard to kill these tumor cells in solid tumors because they have this acidification around them. And the acidification is preventing chemo and immunotherapies and radiation therapy. Well, that acidification is coming from as waste products from glucose and glutamine. So all you have to do is target the glucose and glutamine, remove the acidification, and now these damn tumors become vulnerable to all these other attacks. It's just unbelievable. When you understand the nature of the problem, the solutions to these problems become a lot easier and a lot less toxic than what we're presently doing.
I love the way you're explaining. I mean, I understand it so clearly because I've studied this for such a long time, but I know that the average person doesn't understand the pathways and all that. But I did want to ask Dr. Seyfried. So you said that there are certain cancers that are transmissible. Do the dogs, speaking of, because a lot of people have dogs as pets, do these transmit to humans or is it just transmissible within the same species?
No, I think it's just within the same species. They don't usually transmit to humans from dogs and from Tasmanian devils, these kinds of things. They're usually within the species itself. You don't get transmissible cancer from one species to another. There's no evidence, scientific evidence, to support that. So I'm not gonna. Dogs are dying from cancer as readily as we are, but they're dying
Yes.
from the same problems. They're obese, poor exercise, and from the mitochondrial damage. So almost all cancers are the result of diet and lifestyle issues or exposure to these provocative agents. So cancer is the number one killer of dogs. And you can see these dogs, they're eating crap food. They're not
That's right.
getting the food. And then when you tell them, raw meat, exercise and raw meat will make your dog much healthier. Many vets say, "Oh, you can't eat. The dog should never eat raw meat." I said, "Why? The damn wolf eats the chickens and stuff. All dogs came from the wolf." And you have to question the logic of some of these veterinarians. Oh, they have salmonella. Well, you're not going to give your dog crap off the street. You're going to wash the food. You're not going to be giving him some rotten thing that's been hanging around in the backyard for 3 weeks. I mean, so any logic that the dogs will eat raw chicken. That's how we got that one dog, which we published the paper, mast cell tumor on the face of this pit bull dog. And the owner just listened to our YouTubes and cut the calories of the dog, gave the dog fish oil, raw eggs, raw chicken meat, calorie restricted, exercise. And the next thing you know, this mast cell disappeared from the dog's face. And the dog died of old age, 15 and a half years from heart failure. The cancer never came back when the dog was 7 years old when it was diagnosed, and they said it was going to die from radiation and the toxic poisons of radiation and chemo. They want to give the dog chemo, and it makes the dog terrible. And the owner said, "I don't want my dog getting chemo." So they did the metabolic therapy, and we put all the dietary in there. We looked at the hasa, we did all that. And now people, yeah, people with dogs, they want to see what can you manage your dog with cancer, and the answer is absolutely. So dogs are a new segue into managing cancer using metabolic therapies.
Absolutely, because again, when we take any species outside of their normal diet, obviously and especially for us humans, for our species, all of the refined foods, highly processed foods, these are also provocative agents that go and cause the damage to the mitochondria, right?
Yes, absolutely. And there's another weird thing that's coming out now, this Petrose paradox. Did you know about that? Have you heard about this?
No, no, please tell us.
This is nuts. They say big animals. Why do big animals like elephants and giraffes and these kinds of things, why they don't get cancer? And they say, oh, they have a lot of extra tumor suppressor genes and all this nonsense. So that everybody, it's like, oh, why the big animal? Because the damn elephants and giraffes are eating. They're eating their normal diet. Okay, why don't you take those giraffes and elephants and give them bushels of jelly donuts and pizza and let them drink Coca-Cola. Let's see what's going to happen. Let's see if they get cancer. They had a polar bear at the zoo in Chicago. Can't remember the name of the zoo, but for years people were throwing it marshmallows and all kinds of candy, and of course the bear loves sweet things, right? And then it got really sick, and one of my colleagues had pancreatic cancer from the people throwing all the food to it. Now bears in the wild, they're eating seals and fish. They don't get marshmallows and Hershey bars thrown at them in the Arctic, right? Same with the elephants. I don't know how many pizzas and jelly donuts and bagels an elephant would have to eat for how many years before it got a liver cancer, some damn thing. But Petrus, yeah, big animals don't get cancer. They had a study on monkeys. This was another interesting study down in South America, where they took these monkeys, some sort of New World monkey, I can't remember the species, but they rubbed chemical carcinogen tar on the skin of the monkey, hoping to induce some sort of melanoma or skin cancer. It wasn't working. And the monkeys were eating their normal diet. And then they said, well, we're going to have to inject the monkeys with this chemical carcinogen, feed it to the monkeys, inject it with them. And after 10 years, one of the monkeys in this group that was being treated got some sort of a lymphoma. After 10 years of being brutalized by this chemical carcinogen, and the conclusion of the experiment was monkeys are not a good model for cancer. The monkey was never put in an abnormal environment. The monkey was eating the same stuff that it always ate, and it's living in its kind of a normal lifestyle. What you got to do is you got to give that monkey Coca-Cola, sweet tea, grits, waffles. What is it called? All that stuff the Southern people eat, all this kind of stuff that we're all eating, put in a big hero sandwich and make sure he gets no exercise, and then have a panther walk around the cage every night, putting the fear of God into this monkey. Then all of a sudden you're going to find out he's going to be a very different species. He's going to be more susceptible to all kinds of chronic diseases because that's what's happening to us. We're doing this to ourselves. No exercise, massive stress, poor sleep, eating crap food, and then we get all these chronic diseases, including cancer. No, this is not a mystery. The problem is you can't do that to these animals because it's called animal cruelty. When I went to the zoo down here in Boston, the Franklin Park Zoo, the gorillas there, I said, do you think the gorillas would like donuts and pizza? Oh, yeah, they love them. I said, why don't you go out and get the big box of Dunkin' Donuts? Oh, no, it's animal cruelty. They told me giving the damn gorilla would be animal cruelty. Well, the vet's there eating the donut. We're the same genetically. We're very similar to the damn gorillas and the chimpanzees. And these guys rarely, if ever, get cancer. It's the fact is their environment. It's all genetic. Diet and lifestyle. Change the diet and lifestyle, and you will see what we're experiencing as a species.
I'm waiting until the day when these kind of things become human cruelty. That will be a good day.
Well, we have an obesity epidemic, and nobody seems to care about that. So, it's just, people have to become aware. It's knowledge. Knowledge is power. When you lack knowledge, you have no power. You have no clue what's going on. When you
Tony
become
Robbins
knowledgeable,
has said that. Yes, absolutely.
yeah.
Dr. Seyfried, so how does stress become one of these provocative agents that causes damage to the mitochondria?
Yeah, that's a very good question because when we have stress, we have elevated glucocorticoids,
Mm,
and that raises and it's for our protection. Normally, if we were to see a predator coming at us, we would be stressed. We would have to up regulate our adrenaline and corticosteroids, and run or fight the animal. But or another member of our species trying to kill us. All of these are protective responses, acute. They usually come and go quickly. But when in our modern society, we have a lot of emotional stress, chronic
yes.
stress from all kinds of things, whether it's financial stress, emotional stress, all different kinds of stress. And one of the things in the Press Pulse therapeutic strategy is stress management. We have to consider stress management as, like you said, with hyperbaric oxygen. Hyperbaric oxygen creates metabolic stress in the tumor cells, not in our normal cells. So when you're in burning ketones, the normal cells get super healthy, where the oxygen radicals increase in the tumor cells, and the hyperbaric oxygen then acts like radiation, but specifically kills the tumor cells without harming the normal cells. So we do, I don't know, massage therapy, music therapy, anything to reduce your overall stress levels. And then we have all of these far less toxic approaches for managing cancer. And that was all put in our Press Pulse therapeutic strategy. So we have that. And we just published a major paper in Biomed Central Medicine for a treatment protocol for managing glioblastoma, brain cancer, but it can be used for every major cancer. And we discuss all of these various approaches for managing cancer as a metabolic disease. And it will be instituted eventually into all of the ways you manage cancer, because we've already written not only the framework, we have now fleshed out the framework, and we have shown all of the options that people can have depending on age, gender, religion, culture. So we can modify these therapies to fit almost everybody's condition, and we've told people exactly what. Of course, there's a lot of information here in this, but we've given them what can I do if I can't do this? Well, you can do that. What if I can't do that? Well, you can consider this, and we have all of these different protocols, and we have many physicians, scientists, and nutrition and dietitians that have all contributed together with us on this paper. So clearly we have the framework. We are ready to go on this whole thing to transform the entire cancer industry over to a disease that's manageable, but it's not happening for various reasons that I've already mentioned.
This is so important, though, because at least listening to you, they could get the hope that it doesn't have to be looked at as a death sentence. And even what you said earlier, that there are people who have lived with tumors and with cancer inside of them for many, many years without even knowing some of them. Um, but I have to ask this question, Dr. Seyfried. It's very controversial. I had Dr. Malone on my show, and we talked about the mRNA technology. Is that a provocative agent that can actually lead to cancer?
Well, there's a lot of papers that are coming out. I don't know about the mRNA vaccine. I do know that the COVID virus itself is attacks the mitochondria. So the COVID virus itself is provocative towards not only cardiovascular disease, but also cancer. Now, how do we separate whether the cancer came from the COVID or came from the vaccine? And the
Hmm.
answer is we don't know. We would have to have control groups of people that would get a large amount of vaccines, and we would have to get people who have COVID that never got the vaccine, and we would have to compare and contrast mitochondrial function and various parameters in these people. Who wants to do this? Nobody wants to do this kind of an experiment. So the answer is the work of Doug Wallace, a leader at University of Pennsylvania in mitochondrial biology and physiology and biochemistry, has found that the COVID-19 virus itself can damage oxidative phosphorylation. And there's been a couple of other papers like that. And then people say, oh, well, some of these mRNA vaccines, they're speaking without having knowledge. And the answer is we simply don't know. We haven't done enough studies yet. But what difference does it make? Oh, I got this cancer. It's called a turbo. I don't care what you call it. It can't live without glucose and glutamine, period. We kill turbo cancers as well as we kill any. We don't discriminate. Metabolic therapy does not discriminate.
It doesn't like cancer. It just goes after
equal opportunity killer.
Equal opportunity. I love it. I love it. I think that based on what you said up until now, Dr. Seyfried, it's if I can conclude, most things that are outside what is normal for our species, what is natural for our species. So our natural diet, a healthy lifestyle, obviously no stress, I mean, or at least as little stress as possible, definitely not chronic, is what actually keeps our mitochondria healthy. And all of those factors come in, irrespective of what their source is, it's going to damage our mitochondria. And it's all those things that we have to make sure that we keep in mind and we keep on top of so that it doesn't go and do the damage that will eventually lead to cancer.
That's right. And exercise, I can't speak highly enough. It keeps your mitochondria healthy. You get more oxygen into your lungs. Blood circulation is much better. That together with maybe intermittent fasting and
Yes.
maybe small levels of like a bulletproof coffee. This is unbelievable too. You put some medium chain triglycerides and butter into a freshly potted coffee and shake it around. And then when we have the glucose ketone index, we're working on apps now for the
Right.
glucose. So everybody can use the Keto Mojo meter to measure blood sugar and ketones. At any given moment, they will know what their GKI is. And we're linking the glucose ketone index to zones of health. So if you're in the super high GKI, you're actually in the zone for risk of cardiovascular disease, cancer, dementia. You're in the risk zone for all kinds of chronic
That's
diseases.
right.
But then you can go into the orange zone, the yellow zone, and then of course in the green zone is our Paleolithic lifestyle. And we don't stay in these zones because we like our lives. We like to go out every now and then and have a big meal and enjoy the environment. Okay, which fires us out of this green zone for, I don't know, 20 hours, 25 hours, and then you're back into the zone again. So where do you spend most of your time? And it's all, once we have it into our cell phones, these apps will be in your cell phone. You'll have continuous
Amazing.
glucose ketone monitoring. So anybody at any moment will know what zone they're in, what for whatever they're eating or whatever they're doing. So it's
Perfect.
going to be a transformative way to maintain health once, and we're working on all that right now.
When do you expect that to come out? And for those who are listening, GKI stands for glucose ketone index that Dr. Seyfried
Yeah.
was talking about. When can we expect that, Dr.
Well,
Seyfried?
well, we have to wait for the federal government to recognize the power of what we're talking about. Once they do that, then they'll come to deal with a lot of these chronic diseases real quick. We also have the Broken Science Initiative run by Greg Glassman and Emily Coomer Kaplan. Greg Glassman was the former owner of CrossFit. You heard of everybody's.
Oh, yes.
He made CrossFit a household term. He's trying to set up this new concept called MetFix, which is going to be integrating all of these different strategies and making it on a platform like former CrossFit. So it's going to get into all the different communities, underserved communities. So all people will be able to know what their status of health is at any given moment, and they'll be trained by people and work with people to know how they can be transitioned from one stage to the next. So this is the exciting future. This is going to happen because we know what to do and how to do it. The proof will be in the pudding. We're seeing remarkable therapies right now, but I think we can make this so much better. It's going to be incredible.
Yes, I was going to actually ask you, what does the future of oncology look like if the metabolic theory becomes more widely accepted, which we're all hoping it does, and what you're working on right now that excites you the most? Is there anything else outside of this work that
Well,
you just
it's
mentioned?
the challenge itself. And we have to go through these paradigm changes. They're resisted always because you're challenging the status quo. People are presently comfortable right now, at least the oncology academic communities, the pharmaceutical companies, the hospitals. The revenue generation from the status quo is enormous, and bringing in metabolic therapy will disrupt that to some extent. But that doesn't mean we can't adapt. We can't adjust and adapt. And we have to think of how to transition revenue generation, because I think that has to be a real part of it too. And that's going to require entrepreneurial skills. That's going to have to open new kinds of industries that I've mentioned to you, because this is a transformative process, and like any transformative process, you can't come into it too rapidly. Otherwise, you get massive chaos, and you get all it's like the Wild West, and you get people that are telling you this and telling you that without the credibility that they should have, and people could get harmed. So you need to have a slow transition, probably a hybrid system, where slowly we integrate metabolic therapy in with current standards of care, and then find out how this starts to improve by readjusting these kinds of approaches. And that has to be trial and error. Basically, how people are doing. The patient and the oncology group must work together as a team. The patient now shoulders a lot of this, so they have to become knowledgeable. They have to
Mhm.
work with a knowledgeable physician who understands the concepts, and then we'll see what happens. But clearly, what I'm talking about is based on hard science. What we are currently doing is incorrect. It's based on a misunderstanding of what the nature of the problem is. And once you understand what the real issue is, then you must adapt to this new system if you want to stay healthy. But it's going to require knowledge, and and the challenge for me is in the journey itself. The journey itself, the challenge of the journey is really interesting, not only on the science pathway, but also on the societal recognition of this, and the industry's recognition of this, and the government's recognition of this. So everybody's going to have their own. Oh, they do this. Well, all I know is the science is what's going to eventually bring us to the right path, and we have that pretty well under control. It's all the other things that are standing in the way. So we have to adjust that system, but it's the journey, and that's what's exciting.
Yes, thank you so much, Dr. Seyfried. I just want to, from the bottom of my heart, I mean, thank you so much because it helped. Your work has helped me so much when my dad got diagnosed, and of course, like the studies that I've done. But more importantly, you have really made people understand. You've simplified exactly what it is that causes cancer, exactly what we can do to mitigate, that it's not a death sentence, that there is so much hope. You've put out a call for the medical industry to really embrace all of the work that you've actually put out for people to understand and even to utilize on the path of healing. And this has been such an important conversation because I believe that healing begins when we shift out of the fear and into understanding. And you did say knowledge is power, and all of your work gives us that. I really wanted to make sure that the audience understands. So thank you for reminding us that
And and,
food,
and
mitochondria, the intelligence of the body are not separate from medicine, that in fact they are medicine. Is there anything else that we can expect from you? Another book, perhaps?
well, right now, our big paper just came out on the Warburg hypothesis and the emergence of the mitochondrial metabolic theory of cancer, which sets the entire framework for where we are and where we're going. Yes, it's a technical paper. It's made predominantly for scientists in the field, but people want to know what it's like to paradigm shift the whole industry. That's the information that you need to know. Um, and people should know that all of our research is supported, I said, by philanthropy and private foundations. We
Thank you
get
to
we
those
get support
individuals.
directly to Boston College. Our cancer fund keeps our preclinical systems going. So I work with MDs and PhDs, and we do preclinical studies. And all this, it requires money. And so and there's a lot of people, some people I should say, that just want to be part of the movement and change, and they don't feel that giving us money they have to get something in return. What they get in return is a paradigm change, and there's some people that want to be part of that, and we appreciate those folks because they're keeping us going.
Yeah, so a huge shout out to all of the academics and everybody that you work with. And thank you, everybody who contributes to this incredible and amazing work that will shift the narrative and will shift the paradigm. So thank you to everybody, and anybody that wants to contribute, please reach out to Dr. Seyfried. Please reach out to Boston College and inquire about how you can help and if you have a donation or anything else. Dr. Seyfried, is there anything I have not asked you that the audience would benefit from knowing that I haven't touched on yet?
No, I don't think you did a magnificent job in covering all the key bases. I mean, I didn't get into the biochemistry of how ketone bioenergetics works, but I don't think we need to. It's in the paper. If anybody wants to know that, they can go in the papers. Don't forget, all of our papers are open access, so anybody that would have a computer can easily go in and read the papers themselves. Because they ask me all these questions, and all of those questions are answered in our variety of papers that we've already published. So reading the papers will give them the knowledge they need to know about, because I can't go into every minutia of detail on these things, but the detail is in the papers. So thank you very much for the interview.
No, thank you so much, Dr. Seyfried, not just for your time and your wisdom, but for the ray of hope that you put out to everybody. I've seen you on multiple podcasts, and I really want to empower everybody to listen to your work and to listen to what you have to say, because it really is a ray of hope so that they don't have to accept the fact that cancer means death or that cancer means suffering. There are so many tools, as you said, in the toolbox that they can take advantage of and even go and work with their oncology team to be able to implement this important tool of obviously food and metabolic, just taking it in from a metabolic perspective so that they can actually empower their body in the way that the body will obviously work and interface with the traditional therapies. This is such important work, especially in the world of cancer. So thank you so much. And I really hope I could have you back if there's anything else that comes out on the horizon in the work that you do at Boston College. I would love to have you back so we can continue the conversation.
Well, thank you very much. It was a pleasure to be here.
Thank you, Dr. Seyfried.
Thanks.
That was powerful, everyone. And if you're anything like me, your perspective on cancer and on healing just shifted. What if the answers we were looking for were never in another drug, but in our metabolism? And what if the healing started not with fear, but with food and with breath and with mitochondria and with truth? So if today's episode with Professor Seyfried stirred something in you, and if you learned something, felt something, or thought of someone, I want to ask you for a favor. Please share this episode. Forward it to someone you love, post it on your stories, tag me, and let's get this message out and into the hands of those who need it the most. And let's talk about it. Leave a comment, send a message, subscribe to the podcast, and leave a 5-star review, of course, if you felt the impact, because it helps us reach more people. It helps us spread the hope, the ray of hope, and you become part of the mission, and you help Dr. Seyfried move this into the world in a way that it's meant to, so that it can be used as a tool. Because healing isn't just personal, it's really collective. And these are the conversations that move the world. I'm Simone Gisandi, and this is Health Confidential. So until next time, my friends, keep questioning, keep nourishing, and keep coming home to your power. Remember, healing is your birthright. I'll see you on the next episode.